with the California Healthcare Foundation, and we're delighted to invite you to our webinar. Dr. Kathleen Clannon from Alameda County will be presenting on bringing clinicians together around common prescribing guidelines. As you know, CHCF is working with 17 coalitions across 24 counties to support safer prescribing practices, expanded use of naloxone, and medication-assisted addiction treatment. And of all these, safer prescribing practices is extraordinarily difficult, bringing physicians, physician assistants, nurse practitioners, dentists, all of those who contribute to the volume of opioids in a community, getting us all around the table to figure out what is the best approach to make sure that we're prescribing judiciously and appropriately. Because this is such a difficult topic, we're going to be hitting this topic in a few different ways. We had an office hours a few weeks ago with Dr. Marshall Kubota from Partnership Health Plan, talking about his experience bringing clinicians together across their 14 counties. And Dr. Clannon will talk about her experience in a very grassroots approach doing the same thing with Alameda County. We're very interested in your feedback about what you would like to learn and in what format, so please do reach out to us if you have suggestions. And as always, these webinars will be available on our public website. If there's anyone that you would like to have see the slides or the presentations, this will be available to you. So Dr. Clannon, thank you for coming today, and we look forward to your presentation.
Thanks, Kelly. Yeah, so as Kelly said, I'm Kathleen Clannon, and my day job kind of is that I'm an HIV doctor. Came out of that tradition over the past 20 years. And I got interested in this topic when we first got access to an EHR, and I did a report on what medications my personal patients were on, and discovered that Vicodin was in the top 5. I was completely shocked by that, although my nurses were not, as you can imagine. And that was kind of my entry into thinking about this issue of safer opioid prescribing as one that I needed to personally be looking at in my practice, and then also in my job as Alameda County's Healthcare Services Medical Director. So I'm going to be talking about the very messy and organic process that we've used over the past year to focus down on a few of the more robust guidelines for us to implement in our safety net. So the nature of the problem, of course, is that there are many different complex kinds of recommendations that are coming out in terms of, as you can see, the California Medical Board and also the CDC guidelines are going to have at least that many number of recommendations, or likely more, as they're evolving. And it is basically very difficult for people to focus on more than just a couple of items at a time. So, and we know that clinicians in the safety net clinics are really struggling at the moment. I would say it's a difficult time for us all. And there are lots of things we're being asked to focus on. We're asked to look at SBIRT, we're thinking about ICD-10, trauma-informed care. There's a lot that's out there, and this thinking about how we can actually move forward, not just to adopt, but actually to implement new behavior changes in our clinics around the issue of opioids. We really realized in our coalition that we needed to focus on just a few things that we would really hope to get moving forward in this first year. You all know that consistency among different clinics is really critical, especially around these opioid practices. One clinic in our county made the decision that they would no longer accept new patients who are on chronic opioids. So every patient calling into their new patient line was given that information by the schedulers. They were just told, if this happens to be an issue for you, that you should know that we won't be prescribing. And you can imagine what happened next. So a lack of consistency among different clinic sites really is something that is confusing to patients, and it results in disruption in care frequently. So for all those reasons, we decided in our county for the safety net clinics to come up with a short list, a kind of focused list of particular guidelines that we were going to target for implementation, really powerful, high percentage implementation in our first year. So when we thought about what we wanted that list to look like, we of course had a long wish list of principles for the interventions we were going to pick. One was that they would be evidence-based, so that we would feel confident that we were implementing something that wasn't just a matter of a fad of the moment, but really something that we were confident would result in better care for our patients. That it should be high impact, not just the easy things, but things that were likely to make a difference for a lot of patients or for patients who were really ill or in danger. That it be measurable. It was important to us that we have interventions that addressed both reducing the number of people we were starting on opioids with risk of becoming chronic, and then also interventions that would address those who are already on long-term opioids. Should be easy to remember, kind of a sound biteable thing that people could remember and check in their minds easily. It was important, as you can imagine, to the clinicians that all of the interventions not land on the clinician, that it not be all new tasks for the prescribers. That it would be unlikely to produce opioid refugees in the sense of cutting people off. And then finally, that it would be a mix kind of things that were easy to do and hard to do, so we could have at least some relatively easy wins. So that's what we were looking for in terms of kind of our Prince Charming of set of guidelines. I'm going to take a second just to talk to you about who the we is there. We love our coalitions in Alameda County. This is the first time I've ever had the honor to be in a coalition of coalitions. The grant from CHCF actually helped to connect 3 existing groups that were already doing some work on this. So there's the MEDS Coalition, the green dot. That was the oldest group. It actually came out of a community-based effort for senior injury prevention. And that group focused on medications as a cause or contributor to injury in seniors, and ended up actually focusing on public education generally, but also specifically on education around drug disposal. So at the end of the life of the pill, making sure it gets out of the medicine cabinet and into a safe place. The ACCMA is our local medical association, Alameda Contra Costa Medical Association. They've kind of focused on the hospital emergency departments and private docs. And then in the purple dot there is the coalition I'm talking about, which is healthcare services agencies, so the county health department led, and really works with the safety net clinics. The 3 of us are connected together, and actually there's been a lot of richness in us sharing our goals. Here's what the safety net coalition looks like. There's the county, which is where I sit, and we have contract dollars and also just lots of mutual cooperation with 8 community health centers. They have 32 different sites, and then with our public hospital system, which includes now 4 hospitals and also some freestanding clinics. So that's really what we think of as the safety net system. There obviously are other private providers, et cetera, but this is kind of the core of who it is that we're working with. And one challenge is that this is not a unified system. That the community health centers, the public hospital, and the county each have a different board of directors. They have different strategic planning. There are something like 20 medical directors or CMOs in this. So we don't really have the option of doing the Jean-Luc Picard make it so approach. We really have to work with coalition and pulling our concerned stakeholders together is the only way we really can make progress. So here's what we did in terms of how we consulted and engaged people in the process. So the first thing that we did was put together a large group. We had about 70 people that came together last year to do a brainstorm looking through guidelines that already had existed and practices in other communities. And we asked the group to kind of prioritize that list. Then we took that to our series of small groups, first going to the clinical group, since we thought that they would have the most their behavior would be require the most change in order to implement these things. So they did their own prioritization. And then we asked the other groups to weigh in. We have a community group and a data group. So they did their own riff on the guidelines as they were being developed, our prioritized list. And then we realized that we really needed to get separate buy-in, not just from normal prescribers, but also those who were clinical leaders so the CMOs, the medical directors, et cetera, that they were really ultimately going to be responsible for implementation, so they needed to have their crack at it. And then our last step is to poll some of the prescribers to see, do they see feasibility and are they really bought in? That has led to will be leading to our list of guidelines for prioritization, that we will put our education resources and our work together in our groups into implementing them. So I'm going to walk you through the several iterations of guidelines, and you can see kind of how they evolved over the course of this series of people. We have, I think I counted the other day, we have over 90 people who have weighed in on these guidelines in one way or another. And it's getting tighter and tighter to something I think we're going to really be able to implement and be proud of. So what do we started out with a large group brainstorm. You can kind of see here the different kinds of people that we had at that gathering. We always have environmental health as part of our gatherings because of our focus in this county on safe drug disposal. So they may be not folks that you've had as part of your coalitions, but they're very steadfast members of ours. We had representatives from our other two coalitions. A population that we did not have, although we tried to get a couple people, is people who are actually on chronic opioids. And one of my goals is for us to do a better job of engaging those folks in this conversation with their experience. It's hard to get them to come out because of the stigma. We did, however, have in our community representation the 2 parents of children who'd been lost to overdose, in addition to community people without that kind of, very powerful connection to the topic, but who were interested in what was happening. So this group went through a consensus matrix process in order to prioritize the guidelines. So I'm going to click through to the whole document here. You can download this document if you're interested later and see if you can make it work for you in a prioritization process. So here's what we use the consensus matrix for is we had a long list of possibilities. We thought it was likely that there would be a very high percentage of agreement with a few of these things. And we wanted to be able to agree that we agreed about those things and move on to having our time around the things where we really needed to have more discussion. So, and as opposed to doing sort of dot prioritization, the usual technique of putting butcher paper on the walls and having people vote with their dots, which humans being humans, people immediately start to think, how can I game the dots? Can I put all of my dots on one thing because someone else is voting, So we're so ingenious that way. Rather than do the dot prioritization, we gave each individual this list, and they were we presented to them information about what each of these interventions or goals was, and then we asked them to affirmatively either circle the X for disagreeing, circle the green arrow for that they had agreed, or to say that it needed more discussion. And we told people they could not put needs more discussion on more than a couple. We had them grouped into public education, clinical guidelines pieces, non-opioid interventions, and management of the opioid-dependent patients. And you can see, if you're looking through it, you can see that there's kind of a mix of specific interventions, like you can see here. Conduct population-based reviews. Those are particular sort of granular things to do versus policies that we were going to be recommending or adopting across our coalition. This worked really, really well, and I want to say that I totally stole this from somebody at the gathering that Kelly and CHCF had at the Waterfront Hotel here in Oakland. I can't remember who I stole it from now. Anyway, it was really a great technique, and I'm going to be using it in other consensus situations, and I recommend it highly. So we ended up, not surprisingly, with a whole bunch of things that everybody agreed on, and we were able then to say, okay, these are now in the pot, and we're going to go ahead to figure out how to get it to the smaller list. So here was the prioritized list that the brainstorm, that the large group resulted in. So this is about 20 things that they agreed were things that we really needed to do. There were, as you can imagine, there were some things on which we really could not agree on. And I thought you might be interested to see those. Each of these had at least some proponents, but they had enough disagreement that we decided that we would put them aside for now and move on to the ones that we knew would be high impact and that we did have agreement on. So I'll be interested in the chat and in seeing what you think about these. Just pulling a couple out. This top one here, the question of is it ever appropriate to have as a goal leaving people on chronic opioids, that's something that actually continues to be kind of a philosophical divide, I would say, in our coalition. Is it always a compromise to do that, or can we say, no, this is a good outcome for some people if they're on a safe, what we consider to be a safe dose? We also, I think the rest of these are fairly clear. The other knockdown, drag-out fight we had was about the prior authorization process. The health plans, of course, can do this, and the question for us was, should we approach our local health plan and actively ask them to put this in place? Now, of course, people in our group know that the health plans could decide to do it anyway, but the question was, should we actively court that? And this one was, we had people very strongly on each side, to the point that we almost actually lost a chunk of our coalition who felt that they just couldn't live with that the limitation of the freedom of individual clinicians to make decisions for their patients. So this was, I think, a really interesting list, and you'll see as we go further how different groups kind of dealt with that as we continue to work through our process. So at this point, we had 20 yeses and a series of no's, and including one, oh, hell no. So the next step was we went to our 3 working groups, the clinical group, we have a community group, and a data group, and asked them, here's the list of 20, which ones would you pick out and why? So the clinical group went first, and this is their, when they weighed in, these were their top priorities from the large group list. I'm going to walk you through them because I think it's a really interesting list. So the first one was that they thought that providers needed more education about how to monitor people on chronic opioids for physical risks and also how to educate patients. This ultimately, by the way, morphed into some interest in the difficult conversations. How do we have difficult conversations with our patients about needing to peel them off or down on large doses? They also endorsed population-based reviews. They really wanted a system of evaluation or a kind of clinical peer advice panel so that there could be some relief for an individual clinician in sharing the especially conflict-laden conversations with patients. They really wanted to see a multidisciplinary team that would be available to support patients in weaning down, and then felt very strongly that more resources needed to be directed to the non-opioid pain control methods. And we had some very rich discussion about the wide range of those things and the different cultures that our county is rich in, about the different kinds of healing that people indulge in, and how do we make sure that we're listing all the ones that are culturally appropriate and really making them easy to get to. So in the clinical groups ruminations, these 3 things were, as I said in the title, discussed and advocated, but ended up not making the cut. And I was personally went down to the wire on the morphine equivalent dosing limit, because I do feel that that one is one there's enough evidence for. But my clinicians feel that there is actually still some evolution on the data in terms of where that line should be drawn, and we're uncomfortable with endorsing it. And then you can see the other 2 there in terms of both why they came up, why they had a lot of agreement, but ultimately why they didn't end up on the clinicians list. So I want to make some observations about what the clinical group came up with. First of all, they named it the high 5, and that can recognize that that has some, that we didn't keep that name ultimately, but we had a good time with it during several parts of our process. So if you think about what the clinical group's choices were, they are, for the most part, they are things that really talk to the extent to which clinicians feel that they need more support in dealing with the problem of opioid misuse and overprescription. That they really had to do with we want more support, we want more options. We want we don't want to be hemmed in. We want to have more ability to kind of customize and really deal with the needs of our individual patients. They really tried hard to avoid the opioid refugee problem. And then my major concern about this list was it was very difficult to measure the things that were put in there. So for instance, we could say, is there a policy in place that allows peer consultation? We could measure that as a yes, no, maybe even how many patients went through it, but would be difficult to then translate that into much in the way of a real success metric. My other concern was that it mostly approaches, their list mostly approaches the people who've been on opioids long term and really had very little to do with how to manage, how we drastically decrease the number of people we're starting on opioids. So that was my observation about their list. In general, the clinical group really, just to encapsulate it, they really were worried about how they were going to continue to help their patients with their pain, with the changes that we were talking about. They put a lot of effort, actually, really good effort, into developing this list of pain management resources in our community. We'd be happy to share this with you also, because it's turning out to be a very useful document. So it goes through the modality of adjunctive therapy, where you can get it, where it is geographically, how to click through to it, and also a really big deal, the payer, how it is that people would pay. So we focused on acupuncture, Chinese medicine, chiropractic, and then counseling, especially group counseling that was available for people around the issues of mindfulness and pain control. And we did, as you can see, exercise, massage. We tried to think pretty broadly about the different kinds of things that might be useful to people in terms of managing their pain. So I was very proud of our group, of our clinical group, in really putting work into where their hearts were in terms of being able to build out and map for us where the resources were. So once again, you can download that whole list if you're interested to see what it might look like in your own community. So after the clinical group had their list, then the community and the data groups added their ideas. This is the community group here who thought through what the clinicians had come up with and had their own gloss on it, their own ideas. This is after all the groups had contributed. This is the High Five version 2. So you can see, I think I'll give you a second to read through here. Patient education, reducing new starts, so that got added to the list. Cures, co-prescribing of benzos, and then reducing the number of patients on high-dose methadone. So this is starting to be a little more in line with what our principles were, and also has has the advantage of starting to look like it might be more measurable than what the original clinical group list looked like. So here's just some observations about High Five version 2.0. There are 5 of them, which is good, not 7, which we are a later version of the High Five has 7 things in it. This one was 5. It's looking to me much more evidence-based, and I think probably higher impact in terms of the number of people whose prescriptions are likely to be changed, and who we would hope to actually move toward a better or more safer prescribing relationship. All of the groups, by the way, including the provider group, really focused on patient education. We had a lot of back and forth about patient education because of concerns about how we would make it real and make it measurable. Ultimately, because it was recognized by every group as something that we were really doing a poor job of currently, it stayed on the top of our list, even though we do have those concerns about it. So we feel like we are getting somewhat closer to matching our principles, and we at this point gave that list to the clinical leaders. So these are the folks who actually are going to have to be responsible for making it so, for putting policies in place, monitoring people, changing hearts and minds, and all dealing with angry patients, and all that, those pieces that are going to derive from having new policies. So we asked them as a group to say that we were going to be needing their help to support consistency among clinics. They don't have to do that because they're all individual entities, but certainly recognize what happens if there's inconsistency between different clinic organizations. We asked them to really prioritize the higher impact parts, and then just reminded them that they were going to be responsible really for the implementation pieces. And here was their list. You may notice that their list of 5 is more than 5. So that was actually okay at this stage because we have still one more prioritization step. They were very clear that they wanted to include the counseling of patients. As I said, we had what's that really going to look like? They were concerned that it was going to be a box in the medical record that you would check to say, yes, I counseled my patients on opioid risk, and that it would be meaningless and an extra task for their clinicians. We tried to help by taking all the groups through the development of a patient's guide, so that if we could say if all patients got led through a document or something like this, and had a chance to ask questions about it, that would count. Or if people were really having a significant conversation with patients around their pain medication agreements, that could count, as long as it was really there were certain critical aspects that were really covered for the patients, including this list of questions that have to do with really kind of challenging and reminding people to challenging, the ease with which patients and providers have thought of using opioids, so making people think twice about it. We're hoping here to kind of change the demand curve so that patients walk in saying, whoa, that's serious medicine. I don't want it unless I really know I need it. And then walking people through what the health risks are, especially as people get older. So those were the things that the clinical leaders and actually all the groups felt we really needed to do a better job of. So you can see the rest of the list here. As it has evolved, it gets more and more specific. So there's an interest in risk stratifying patients. Who's going to be at the most risk, both physical risk, for instance, people who have sleep apnea have more physical risk for overdose, and also those who may have more risk for triggering addictive behavior. They did put cures on. Interestingly, they added this reassessment of treatment progress. We still haven't for sure nailed this down to whether it's 30 days or 90 days. Cures will support the 90-day limit because they will alert us. The new Cures 2.0 will alert us to folks who have been on 90 days. But our clinicians were concerned that 90 days was too long, actually, and that we may already have produced a problem in some patients within that 90 days. The start low and go slow, totally just trying to overall reduce the number of pills. The co-prescribing with benzos, I'm going to come back to in a second. And then you can see here we're using our population health tools and incorporating that document I showed you a minute ago. So we now have more than 5. This list is a little too long. One more time, I ran it back by our clinical group, and they were struggling around the co-prescribing with benzos question. That was surprising because I thought that was really clearly evidence-based, that was really high risk. It's going to be something that Cures will alert us to. But the the clinicians had a, to me, kind of unexpected reaction to it, which is that they were concerned about producing benzo refugees, and that the withdrawal for benzodiazepines, of course, much more uncomfortable and actually dangerous even than the narcotic withdrawal. And their sense was that primary care providers are very uncomfortable prescribing benzos anyway, and if they had to stop co-prescribing, they might just stop the benzos. So that's where we are at this point with the, with the list. We don't necessarily know which of these is going to last through the last part of our process, but I'm suspecting that the co-prescribing with benzos may end up getting deprioritized. So my observations about this list is it's a very interesting list. It got more and more specific. It's relatively evidence-based in terms of most of the things that are on here, and they are things that are measurable. And the interventions are ones that can be spread around, not just on the clinician, but actually on other members of the team also. Our final step is going to be to survey all of our prescribers and ask them to actually hone it down for us to the real final 5. We, of course, many of the clinics are already doing some element of these, so we'll just be lifting up that 5. It's going to become, it's no longer called the High 5. The CMO group knocked that out and said we had to call it the Focus 5, which one can understand why. But so the SurveyMonkey results are going to help, will give us our final buy-in from our clinicians group. They, after all, are the ones that are going to have to change their behavior. So I think it's fair that they should have the last crack at it. So that is all I had to say about our process. I'm happy to open it up now to any questions, and also happy to scroll back to any slides if people want to see any of the lists again.
Hi, this is Kate from CHCF, and we'd invite any of you that have questions to either type them into the chat box or the questions box. Here's a question for Kathleen. After the prescribers review the guidelines, will they go back to the medical leaders for final adoption?
So no, the clinical leaders agreed that the prescribers survey would be the last word, as long as we picked out 5 out of the clinical leaders list of, I think there were 8 on their list. Any 5 out of their list they agreed to. And I think that's fair. The prescribers are, are the ones still who are going to have to change their behavior the most. So it'll be the ones that they really feel the most confident in.
I think your approach was wonderful. I know how difficult it is to get a group of clinicians and prescribers to agree on more than 1 or 2 things, let alone 5 things. The handling frequency of office visits, the number of days supplied of controlled medications for the patients that are being treated with that. How have you gone about the organization around refill requests and the frequency that the patients are coming in to be seen?
So assuming, as I think is likely, that we'll end up with one of the with one of the interventions that actually kind of focuses around the number of days or the number of pills, then each of my clinic organizations is going to have to figure out for themselves what that policy looks like. And what we'll do is manage that process by kind of bringing them together around what different policies are. Most of the folks that I work with are in FQHCs, and so they are on a visit mill anyway, and it is to the advantage of the practice to actually bring people back for a visit. And the trade-off is with access, with making sure that there are enough appointments for people who need to come in for other reasons. So I'm not really answering your question, Max. I'm going to say that it's going to be whoever, in each clinic it'll probably be a different policy about how people do that. What we will focus on is what is the number of pills or the number of days, and we're going to try to make that consistent.
Good job not answering the question. No, that was actually.
Well, what do you? And I'm interested, by the way. And what do you have any ruminations about that? About what you think is a good way to do it?
Oh, I do. We've been working on this at clinic level for over 2 years now, and one of our clinics with 14 or 15 providers, we've developed an office policy which is spread to other clinic locations as well, which that's why I'm attending this with the building consensus, because taking it from clinic to clinic presents a new opportunity to refine and improve our guidelines. But our current office policy is that I absolutely agree with the go low or start low and go slow, and consider using medications other than opioids as your first line of treatment for painful conditions, especially if it's something that's not anticipated to be chronic pain or prolonged pain, such as a post-operative treatment or things of that sort. But we have it established that medications will only be written for during office visits, and it's up to the prescriber to establish the frequency of the visit, which could be in 30-day increments, essentially. We don't want prescribers writing for less than a 30-day supply, even though you may not be taking a medication 5 times a day. If it's a 60-tablet supply, that's 60 tablets per month. So we may give you up to 90 days, but we will see you 4 times a year at least, similar to the follow-up and guidelines that we have for our diabetics or hypertensive patients as well. So we've tried to establish this as a chronic disease state, as opposed to having a lot of exceptions in one-off because it's narcotics and benzos, which tends to have a high level of emotional content both for patients and prescribers.
I am hoping very much that where we can get to across our system is something that really looks like that, and in which it becomes kind of like gravity, that people don't question it anymore because it is there, that this is the way that we do these things. We've got a ways to go before we get there. And you probably have had experiences similar to mine, which is we can put in place even pretty easy guidelines like no promethazine with codeine ever, period. And we still find that that's at least, it's easy in the sense of being a yes or no. Like you're not unclear about whether you're doing it or not. And we still will find some clinicians who sneak it in, and we'll see some prescriptions coming through. So clinicians were a hard bunch to get to adhere to any kind of party line. So, but what you're describing is really where I hope we get to across our whole system, is to have that kind of container for this work, for the work of increasing opioid safety, that feels a little bit permeable, but is a firm enough container that we know whether we're doing it or not, and patients don't have disparate experiences at different places they go.
Absolutely, I think that's a great goal, and one that we're working for as well.
So I'm going to turn it over to Glenn Siegfried, who we've unmuted, and Glenn wants to know about reaching out to private practitioners that work in solo practice or small private practices and aren't part of large medical groups. And Glenn, I've unmuted you if you want to embellish on that question.
Yeah, we have a separate, as I mentioned kind of towards the beginning, there is a sister coalition, one of our coalitions of coalitions, out of the Medical Society, and they have kind of taken on the cause or the mantle of working with the private providers. What we are hoping to do with that group, many of them are signed up with our local managed care, Medi-Cal managed care organizations. So that's one way that we can kind of help to reach them with kind of some with education, and also making educational opportunities available to them, and also, if they're interested, helping them figure out how they can use their office systems to do some population reports. So that's kind of as far as we've gotten with them. It's definitely a much, much harder reach, both because those small group or single practitioners can be quite isolated and hard to reach in terms of any kind of education, and also because they may not have as kind of their culture really to be adhering to these kinds of policies or initiatives. It's not kind of it's not how they do their practices. So that working with that group is going to be one of our next Next, challenges, and so far we're adhering to, so far what we're doing is giving them tools and opportunities for education and to come and talk about what their challenges are.
Yeah, I appreciate your response because it is a challenge up here. By nature, solo practitioners are independent and they don't like to necessarily follow rules that come from above. So
Yeah.
you kind of echoed what we've been seeing up in our area.
Yeah, the one thing that is working in our favor on this particular issue is that frequently the practitioners and their office staffs are miserable around this issue. And
Right.
that helps both get people's attention and get them out to come to discussions or classes and stuff. And also they have, you know, there's an easy, once you put some kind of policy in place, frequently the calls and the hassling of the office staff and that kind of stuff pretty quickly can be decreased, so that at least they see kind of an immediate benefit in terms of the disruption that they might have been seeing before. So that's just one advantage we have around this particular issue.
Thank you for your response. Appreciate it.
Yeah.
So another question is, Kathleen, how will you measure adherence to the new guidelines?
So we are going to be, we've been doing reports out of the clinics' EHRs. So that'll be, you know, the clinics will have access to their own data. There is a consortium of the clinics in Alameda County that is a business arm for them. It's called the Community Health Center Network. And we can probably get some blinded, you know, clinic-specific but not provider-specific information there. So it depends on which of these things ends up being picked out. And we might be able to get some of it actually from Cures, some of the information. But depending on which of these 8 end up the high 5, we have ideas already about how to get them managed, how to get them measured, mostly out of the EHR.
That's terrific.
I'm afraid that patient education one is going to be the real difficulty, because the CMOs are totally right. What's going to happen is we're going to end up with a box on the electronic health record that says, I educated my patient. And really making that real, I think, is going to be hard, but it's really, really important for us to actually do a really good job of educating patients. I think the only way we're going to manage that is by taking it out of the hands of the clinicians.
Great. So, Kathleen, I wanted to thank you. It's, again, I think there's very many approaches to this this problem, and I love the way you frame it as the card, make it so, versus this inclusive process. And one of the things I've been very impressed by health plans is some of them, like Partnership Health Plan, instead of saying make it so, are really working hard to have provider input as part of that. That's why we brought Marshall Cavoda to discuss that approach. And as CHCF works with other health plans, as they take on more formulary restrictions to try and drive better prescribing, our message continues to be engaging the provider community, because without provider community engagement, who, as you say, are actually doing the work on the front line, having very difficult discussions with patients, we won't be successful. So again, it was a great modeling of there are 2 ways to go. There's a fast way and a slow way, and often when we go the fast way, we find it takes more time in the end because we haven't brought along people with us. So Kathleen, I just want to commend you for modeling a way to get everybody at the table in the beginning, although it takes longer in the end with more buy-in. It will have far more momentum and more impact.